ago it was 65 degrees outside, and this is what we've got today. So I know there's a lot of the ladies I spoke with already that are in the local area, and they experienced it, but unfortunately you guys aren't. We're here to talk today about infection control, and as a disclaimer I have to say that Air Techniques has paid for my honorarium to do this presentation. We're going to talk about a whole bunch of stuff today, and the bottom line is just talking about how to have a very safe dental visit. But how did we get to this point of needing all of this is where I wanted to start my story. 1972. I am going to totally age myself here. I was in dental hygiene school in 1972. The only time we ever put gloves on was when we had a patient that had an overt herpetic lesion, a history of syphilis, or a history of gonorrhea. And I went to Loyola at the time. What they did is they tested RPR, and to see if you have a history of they would never be able to do this now, to see if you have a history of any venereal diseases. If you were shown to have that, we were then allowed to wear gloves. We didn't wear masks. Oh, and by the way, as after I'm done scaling and perio and up to my elbows in blood, we washed our hands, we went to lunch. Didn't think anything of it. You're nodding your head. I mean, we know how this happened. So, we didn't sit down. 1981 happened, and I don't know how many of you remember about 1981 and what this is, but 5 healthy men came down with some symptoms of a rare lung infection, and they also had some lesions called Kaposi sarcoma appearing. By the end of the year, 121 gay men died from AIDS, HIV. And what this is it's the AIDS quilt. And this was created back in 1981. Each square commemorated somebody who had passed from AIDS. So in response to this, the CDC in 1987 came up with universal precautions. What are the universal precautions? Gloves, mask, glasses, and that all fluids are considered infectious. And the reason that we had to do this is to prevent the bloodborne pathogens, HIV, hepatitis, to healthcare workers. So what happened in 1987 is everything started to be covered in plastic. And everything. We wanted to make sure that everything was healthy. I don't know if any of you remember, a lot of people were double gloving. If somebody had something in their medical history, they were double gloving. So, to again prevent any possible catching through the gloves. But it got so crazy is even door handles were covered. Okay, I did this in my office, so people liked this. They wanted to make sure that the offices were safe. Well, in 1986, there was a dentist in Florida named David Acer. David Acer had contracted HIV. He was having unprotected sex and had multiple partners, and found out that he had this disease. But before he even found out he had this disease, he was not doing, this was 1986, he hired an associate. She had requested that he autoclave his instruments. He was not autoclaving his instruments in 1986. Now these rules came out in 1987, but still in 1986, he wasn't autoclaving his instruments. Well, he was using steam to clean them, but not autoclave. Well, he wound up treating patients consistently over this time period, but was very lax in his infection control. He was reusing a lot of disposables. He was reusing gloves around A year later, I think he wound up going to see his doctor because he had a very bad sore throat. The sore throat turned out, he had it biopsied, it turned out to be Kaposi sarcoma. He started the AIDS regimen for drug therapy, and it kind of went downhill very rapidly from there. By the time he sold his practice, I think it was in 1989, he only had, so 20 patients were remaining because people just were left leaving the practice in droves. But before that, he saw a woman named Kimberly Borgalis who had 2 infected teeth. And he wound up treating her, but he also wound up giving her HIV/AIDS. And when he wound up selling his practice, only 20 patients were left. All the other records were destroyed. Now think about that in this day and age. I sell my practice to this young man. I have to give him all of my records for a specific period of time going back. Anyway, what happened was he wound up finally realizing, I mean, he was really bad towards the end in 1989. He wrote an open letter to all of his patients telling him that he had HIV, and 4 months after he died, she told her story because the CDC connected his office to her getting HIV. So this is, again, this is like the extreme problem with infection control. Then they came out with new rules we all had to follow. And again, these rules were the old rules because it was 1987 is when they originally started. This was 90. Again, because of Dr. Acer and contaminating his patient, we again needed to be very well aware of universal precautions. A lot of patients were really freaked out about all the stuff in the news. Anything happens bad, something happens, and then nobody comes to the dentist for weeks, months, years. So what happens is, people were doing contracts with their patients that they were HIV free. There was a practitioner in Northern Illinois that started to do that. People just wanted to be sure. Then there's hepatitis B. The first hepatitis B vaccine was made available in 1982. The reason I explain this to you is in 1982, all dental students at University of Illinois College of Dentistry had to be guinea pigs for this hepatitis vaccine. The interesting backstory to this is not only did we get the injection, we got the injections, all 3, but I found out I was pregnant after the second injection. I called up the company that was manufacturing this, and they had done no studies at all on pregnant females, animals, whatever. So it was kind of interesting. End of that story is I never seroconverted, so I wound up having to get the series again. But now it's in the federal standard that as an employer, we are obligated to give our employees hepatitis injections, or make sure that they at least are documented that they have it. And again, if any of you have little kids, they now have hepatitis regimes for the kids, so everybody is going to be coming up with their injections. Dental offices have always been under scrutiny, and as I said, if something happens with a sedation case, everybody hears about it. That's all you hear about in the stores when you're shopping, when you're taking your kids to school, and then people stop coming to the office. Well, this is clicking too fast. The Acer case was in the 90s. As recent as 2013, there was articles with CNN about how the dental office is a perfect storm for having infections because of all of the stuff that's going on and if protocols aren't followed. Memphis, there was another Memphis dentist that was apparently not working working according to protocol. They wanted their patients tested. And as recent as December of 2016 in Wisconsin, they had the same situation. Dentists may have exposed their patients to HIV and hepatitis. So the primary goal of infection control is to keep everybody safe, to keep us safe, to keep our patients safe. We want to prevent bloodborne pathogens from being transferred. So think about the pathogen exposure that we have in a dental practice. We have HIV, we have all the hepatitises, we have tuberculosis, but there's a couple other things that are out there that we need to protect ourselves from. Can anybody think of one thing that's been amazingly in the news? I'm sorry? MRSA. Anything else? Flu. So, the flu and the common cold. You know, the majority of our patients, we hope, are coming in healthy. But if they have something, they wind up having, thank you. And here's my Vanna White over here helping me. Oh, Jen, this young lady up here said flu. Common cold. So we again have to protect ourselves from even these innocuous things that are getting people sick. There's different pathways of having this transmission. Patient to the dental team. How many times have people come in saying to you, I've got a little sniffle, is it okay? Well, unless you can, if you can't breathe, no, it's not okay, but yeah, it is okay. Come on in. And then on occasion we're sick. I mean, we have colds. Obviously we're not going to be working with the flu, but there's a potential of us transferring something to a patient. We can also, in our reception area, have patient to patient, each of them getting sick, and unfortunately, there's some situations that you've seen with all the documentation I had shown you. Patient to patient, if infection control protocol, the dental team to the community. We can get other people in the community sick, and the community can get us sick, and by the community, I pretty much mean your family. I mean, I've got 2 grandkids that every other week somebody's got strep or sick or whatever, and they can give me something and I can give them something. So again, these are pathways to getting this transmission. Again, 5 major routes of transmission. Direct and indirect contact with droplets, airborne. The droplet is a big deal. When we're working and you're using an aerosol and you have all this spray coming in your face, you really have to make sure that you're covered with your masks and your eyeglasses. If you've ever taken a look at your mask after a procedure, especially an ultrasonic scaling or a prep, a crown prep, when you're right at the marginal gingiva, there is a lot of blood that's going to be squirting up. We can also get transmission if we get a puncture wound when we're touching contaminated instruments. It's another way that we can get touching our eyes when we've touched something and then put our hands to our eyes. Again, it's really important to follow the sterility chain all the way through. And inhalation, again, all the reasons for masks and gloves. Sorry. And again, the way that we prevent the direct contact is make sure we wash our hands and are wearing gloves. With the aspiration, we really have to make sure our suction is good and our masks are well. There's different levels of filtration on your masks. Are you aware of that? 1, 2, and 3. So when you go to the doctor's office and you see little masks sitting there because they want to make sure that you aren't getting them sick, that's usually a level 1 mask. What we're using in the office are level 3, which are really moisture protecting, and that's, you really have to make sure you're wearing that. And also your personal protective clothing. One of the things that I've always had a rule about is I've never let my kids come up to me and hug me when I came straight home from the office. Or if they come into the office and visit me, I don't want them hugging me because I've got whatever all over me. So again, you have to be really careful with the personal protective clothing. You can stick yourself. Again, you have to make sure that you're really taking care of, you're taking blades off if you're using removable blades or needles, recapping needles according to protocol. And again, indirect contact with some of these instruments, you have to sterilize everything that you can or use single use. We're going to talk about that in a sec. I put this in here because it is infection control, and people should be aware of all these things that we touch during the day. And I'm one of those people that walks around with disinfectant all the time. You go to get gas. You go to the gym. You touch the gym equipment. You open up a door. Patients are coming in with this stuff. And then those are the clinical surfaces that we touch that really need to be covered with plastic and disinfected after each use. Where do we look to in our practice for infection control? Your infection control procedures should be in your policy manual. They should be lined out, they should be very well defined, and every single team member should get it, and there should be regular updates. There may be changes, there may be things that you need to remind people about. Somebody might be getting a little sloppy, and everybody needs to look out for this, because one person breaking the chain is really going to be disastrous for the whole office. Every team member really needs to follow the recommended guidelines. It's really important for somebody to sit down with a new team member and go through the guidelines with them, because if guidelines aren't discussed from the beginning of the employment and refreshed, what happens is Susie may be telling Jill may be telling Andy, and by the time it gets to Jen, it's a totally different story. So everything needs to be written down, easily understandable. And the other thing that offices should have is an infection control manager. This person is responsible for making sure the inoculations are in place, the paperwork's in place, where the MSDSs are, where all those things are, that everybody's using the right disinfectant, that if there's any new protocols, the team is made aware of it. I'm sure you all have team meetings or morning huddles, and instead of making them, let's complain sessions about the team meetings, you could have refreshers on infection control at least once a month or once every 3 months. It's really important, and it's, again, it's just repetition to make sure everybody knows, no, that's not how you recap a needle. No, these are still the things that can happen even though it's not, out there. And we still have patients that don't tell us everything. I don't know about you all, but I have people that come into my practice and, oh, was I supposed to tell you about that? Yes. It's kind of helpful that I know what's wrong with you. OSHA has 3 standards that we have to be concerned about that are related to dentistry. One is the Bloodborne pathogen standard, and this has to do with, again, everything has to do with training, but this has to do with the hepatitis injections, it has to do with vaccines, the bloodborne pathogens, and personal protective attire. There's a hazardous communication standards. This is for your MSDS, that you have to have training about what's a biohazard in your office. Things should be labeled as biohazard in your office. You can get the stickers on Amazon probably now to put on areas that need to be on your sharps disposal. And all employees employees need to know this. Because if you have a high school kid coming into your office and they really don't know what they're doing, they're at huge risk. And you are very much liable. And the last thing is, general duty clause, we have to make sure as employers that we have a safe environment for our employees to be working in. And these are the three things that OSHA is very concerned about. These are references. If you want to take a picture of this, I can also get you the handout for this program when we're done. I think Jen has all that information for you. But these are the references that are widely available. And I know that there's regulations that have been changed in the government. This has never been changed in all these years. They add more things to it, but they're not taking anything away. Job safety poster that should be posted in your office just to say that you have a safe work environment, because if OSHA comes into your office, they want to see something like this. So, and these are readily downloadable on their website. It's not something that you have to go out and buy and spend $35 to get. There's a whole bunch of places that you can get training for, the full OSHA training. ADA has a very effective, and I don't work for ADA, but they have a very effective, very comprehensive program that you can use. There's also a bunch of academies that you can, a lot of online academies that you can get. Again, every team member should know and be going through all of these programs. The CDC has guidelines, and these are, again, readily available, readily downloadable, they're free. So if you want to go on your own and do this on your own, you can go to the CDC and get this booklet, print it, and have it in your office. Read it and follow the guidelines. They have infection control and prevention guidelines. It's completely explained line by line what you need to do, what administrators need to do, and again, these are just things. Just go online. And because they also, the Department of Labor also has model plans and programs, so you don't have to recreate the wheel. You definitely need to have a program in your office. It should be written. They have models that are already out there, so you fill in the blanks with what's pertinent to your office. So I might be the resource manager for my office. If you've got 5 or 6 people, you may say for somebody else to be the point person. When that person leaves, that job needs to go to somebody else. There should always be somebody filling that role. The CDC got very smart, and they know that there's a lot of millennials out there that do a lot of things on apps, and they have now created an app for this, for the guidelines, and it's actually kind of cool. I mean, the app features, I know you can't read it on that thing, but you can check and see what the compliance, what's necessary for compliance. You can export records. You can, it will have links to the full Now, you're not going to read it on your, I mean, I can't read it. My eyes are too old to read that stuff on a cell phone, guys. But you get links, and it's free. And this is really a nice little perk that's out there for us as clinicians to be able to have. But again, the one thing that I want to stress about all this stuff is it's all free. And you can take a class, you can work on your own, but this is something that needs to be done because you need to know these guidelines. Personal protective equipment. Again, when we were talking about droplet and airborne and things like that, gloves that really should be, and we have to be very aware of patients that are allergic to latex. I don't have any latex gloves in my office anymore. We switched over completely to nitrile. Instead of pulling out the vinyl gloves and everything, it just got to the point where I didn't want to deal with any latex allergies, which again is another thing that you need to record. So we just totally went into nitrile gloves. It may be a little bit more expensive, but in the end for our office it was worth it. Masks, as I was mentioning, there are different levels of masks. There's several companies around here, actually Crosstech's right over there, has a huge variety of masks, and there's different filtration levels. A mask should be worn once. If a mask gets wet during a procedure, it should be taken off and replaced, as well as your gloves, because you've broken the chain of sterility. If there's splotches all over it, patients see this. They don't want to see that. So masks are again, really important. The interesting thing about masks, I was having a conversation with somebody, and when I was doing research for this program, our glasses come to here. Our masks come to here. There was a study done with like red dye shooting out as it were a spray from a handpiece. There's still a little area that's right around here and back here that if you don't wear your mask the right way and have it covered, the droplets can still go in there. So it's not just the filtration level on the masks, it's properly putting the masks on. Now, I did have a picture of my granddaughter wearing a mask. I couldn't find it. It was like the most improper wearing of a mask in the world. But I don't have it here, unfortunately. But you'll know when your mask is fitting the right way. Personal protective clothing. A lot of offices have outer garments that they discard for each patient. A lot of offices have uniforms that they leave and have laundered at their office as well because of all the splatter. So sleeves, neck covering, you need to be covered. Eyewear. Eyewear must have side shields. And eyewear really needs to have side shields for a couple different reasons. Splatter comes from all different directions, and not only splatter, but shrapnel. When you think as a clinician, when you think as a clinician, as we're taking out a historic amalgam, as I call it, or even a historic composite, you wind up with little pieces of scrap coming at you. So you want to make sure that your eyes, and especially your assistant's eyes, are covered on all sides. Because your assistant's face is right there too. So you really have to make sure everybody's covered. Reusable or disposable? It all depends on your practice, what you want to do. Obviously, my scopes are reusable. I'm not going to dispose of them after every single patient. I would be bankrupt. But there are clinicians that are not wearing scopes, and they can wear glasses that you could discard after every patient. We happen to use something very similar to that for our patients, and it's I'm leading right into this. Did you guys hear about this a few years ago, 2016? A woman was blinded because she was not wearing eye protection. And the reason she was blinded is because, and I did not bring the graphic picture of what her eye looked like, something got dropped in her eye. So there is this Jen's law, Jen's rule. This has been out there for Jen Monroe for a couple of years, and everybody should be wearing glasses. Absolutely everybody. The clinicians need to be wearing glasses. Every single patient needs to be wearing glasses, and not just for laser